Hey guys, welcome to Medifaction. Today we are going to learn about the physiology behind urination. So, how do we urinate? It's not complicated as we think it is. So, let's get into some details. The process of voiding of urine from the bladder is known as micturition. So in this video, we are going to enumerate about some introduction about micturition, the functional anatomy of urinary bladder, urethra and urinary sphincters, the nerve supply of urinary bladder and sphincters, that is sympathetic, parasympathetic and somatic as well. Filling of urinary bladder, that is we are going to discuss about the process of filling and cystometrogram. Also, we are going to discuss about the micturition reflex and some of the important applied aspects of micturition. Introduction. Micturition is a process by which urine is voided from the urinary bladder. It is a reflex process. However, in grown-up children and adults, it can be controlled voluntarily to some extent. The functional anatomy and nerve supply of urinary bladder are essential for the process of micturition. Functional anatomy of urinary bladder and urethra. First, we will discuss about urinary bladder. Urinary bladder is a triangular hollow organ located in lower abdomen. It consists of a body and a neck below. Wall of the bladder is formed by smooth muscles. It consists of three ill-defined layers of muscle fibers called detrusor muscle, which is the inner longitudinal layer, and middle circular layer and outer longitudinal layer. Inner surface of urinary bladder is lined by mucous membrane. In empty bladder, the mucosa falls into many folds called rugae. At the posterior surface of the bladder wall, there is a triangular area called trigone. This here is the trigone. At the upper angle of the trigone, two ureters enter the bladder. Here you can see two ureters entering the bladder. Lower part of the bladder is narrow, as you can see here, and this forms the neck. It opens into the urethra via internal urethral sphincter. Here is the internal urethral sphincter. Urethra. Male urethra has both urinary function and reproductive function. It carries urine and semen. Female urethra has only urinary function and it carries only urine. So, male urethra is structurally different from female urethra. Male urethra. Male urethra is about 20 cm long. After origin from bladder, it traverses to the prostate gland, which lies below the bladder and then runs through the penis. Throughout its length, the urethra has mucous glands called glands of Litter. Male urethra is divided into three parts. Number one is the prostatic urethra, which can be seen here colored in blue. Then there is membranous urethra just below, which is small in length. Then there is spongy urethra, which can be identified in red color, and this spongy urethra is also called penile urethra. First, let's discuss about prostatic urethra. Prostatic urethra is 3 cm long and it runs through prostate gland. The prostatic fluid is emptied into this part of urethra through prostatic sinuses. Sperms from vas deferens and the fluid from seminal vesicles are also emptied into prostatic urethra via ejaculatory ducts. Part of the urethra after taking origin from the neck of the bladder before entering the prostate gland is known as pre-prostatic urethra. Its length is about 0.5 to 1.5 centimeters. This part of urethra is considered as part of prostatic urethra. Number 2 is the membranous urethra. You can see here. Membranous urethra is about 1 to 2 cm long. It runs from base of the prostate gland through urogenital diaphragm up to the bulb of urethra. Number 3 is spongy urethra, which is also called as penile urethra or cavernous urethra. It is about 15 centimeters in length. Spongy urethra is surrounded by corpus spongiosum of penis. It is divided into a proximal bulbar urethra and distal penile urethra. Penile urethra is narrow with a length of about 6 cm. It ends with external urethral meatus or orifice, which is located at the end of penis. The bilateral bulbourethral glands open into spongy urethra. Bulbourethral glands are also called Cowper glands. Now let's move on to the female urethra. It is narrower and shorter than male urethra. It is about 3.5 to 4 cm long. After origin from bladder, it traverses through urogenital diaphragm and runs along anterior wall of vagina. Then it terminates at external orifice of urethra, which is located between clitoris and vaginal opening. Now let's move on to urethral sphincters. There are two urethral sphincters in urinary tract. Number 1 is internal urethral sphincter and number 2 is external urethral sphincter. So here you can appreciate the internal urethral sphincter. This sphincter is situated between the neck of the bladder and upper part of urethra. It is made up of smooth muscle fibers and formed by thickening of detrusor muscle. It is innervated by autonomic nerve fibers. The sphincter closes the urethra when bladder is emptied. Now let's talk about the external urethral sphincter, which you can appreciate right here. External sphincter is located in the urogenital diaphragm. This sphincter is made up of circular skeletal muscle fibers which are innervated by somatic nerve fibers. Nerve supply to urinary bladder and sphincters. Urinary bladder and the internal sphincter are supplied by sympathetic and parasympathetic divisions of autonomic nervous system, whereas the external sphincter is supplied by the somatic nerve fibers. Sympathetic nerve supply. Preganglionic fibers of sympathetic nerve arise from the first two lumbar segments of spinal cord. After leaving spinal cord, the fibers pass through lateral sympathetic chain without any synapse in the sympathetic ganglia and finally terminate in hypogastric ganglion. The postganglionic fibers arising from the ganglion form the hypogastric nerve, which supplies the detrusor muscle and internal sphincter as well. Function of sympathetic nerve. The stimulation of sympathetic nerve, which is the hypogastric nerve, causes a relaxation of detrusor muscle and constriction of the internal sphincter. This results in filling of urinary bladder, and so the sympathetic nerve is called nerve of filling. Parasympathetic nerve supply. Preganglionic fibers of parasympathetic nerve form the pelvic nerve. Pelvic nerve fibers arise from second, third, and fourth sacral segments of spinal cord. These fibers run through hypogastric ganglion and synapse with postganglionic neurons situated in close relation to urinary bladder and internal sphincter. So this is the pelvic nerve, which is innervated parasympathetically, and this here is the hypogastric nerve, which is innervated sympathetically, and this is the somatic pudendal nerve, which we will talk about in future. Function of parasympathetic nerve. Stimulation of parasympathetic nerve causes contraction of detrusor muscle and relaxation of the internal sphincter, leading to emptying of urinary bladder. So, parasympathetic nerve is called the nerve of emptying or nerve of micturition. Pelvic nerve has also the sensory fibers which carry impulses from stretch receptors present on the wall of the urinary bladder and urethra to the central nervous system. Somatic nerve supply. External sphincter is innervated by the somatic nerve called pudendal nerve. This arises from second, third, and fourth sacral segments of the spinal cord. Pudendal nerve maintains the tonic contraction of the skeletal muscle fibers of the external sphincter and keeps the external sphincter constricted always. During micturition, this nerve is inhibited. This causes relaxation of external sphincter, leading to voiding of urine. Thus, the pudendal nerve is responsible for voluntary control of micturition. Here you can clearly identify the somatic nerve supply by the pudendal nerve, and here you can see the parasympathetic nerve supply from S2, S3 and S4 to the urinary bladder, and this here is the sympathetic nerve supply, that is the hypogastric ganglion, from where the hypogastric nerve starts, and here you can see it innervates, and this is the external sphincter, also supplied by the pudendal nerve. Filling of urinary bladder. Process of filling. Urine is continuously formed by nephrons and it flows into urinary bladder drop by drop through ureters. When urine collects in the pelvis of ureter, the contraction sets up in pelvis. This contraction is transmitted through rest of the ureter in the form of peristaltic wave up to trigon of urinary bladder. Peristaltic wave usually travels at a velocity of 3 cm per second. It develops at a frequency of 1 to 5 per minute. The peristaltic wave moves the urine into the bladder. After leaving the kidney, the direction of the ureter is initially downwards and outward. Then it turns horizontally before entering the bladder. At the entrance of ureters into urinary bladder, a valvar arrangement is present. When peristaltic wave pushes the urine towards the bladder, this valve opens towards the bladder. The position of ureter and the valvar arrangement at the end of the ureter prevents the backflow of the urine from bladder into the ureter when the detrusor muscle contracts. Thus, urine is collected in bladder drop by drop. A reasonable volume of urine can be stored in urinary bladder without any discomfort and without much increase in pressure inside the bladder. It is due to the adaptation of detrusor muscle. This can be explained by cystometrogram. Now let's learn about the cystometrogram. Cystometry is the technique used to study the relationship between intravesical pressure and volume of urine in the bladder. Cystometrogram is the graphical registration of pressure changes in urinary bladder in relation to volume of urine collected in it. Method of recording. A double lumen catheter is introduced into the urinary bladder. One of the lumen is used to infuse fluid into the bladder and the other one is used to record the pressure changes by connecting it to a suitable recording instrument. First, the bladder is emptied completely. Then, a known quantity of fluid is introduced into the bladder at regular intervals. The intravesical pressure developed by the fluid is recorded continuously. A graph is obtained by plotting all the values of volume and the pressure. So, this is the graph which we obtain from the cystometrogram. And this graph possesses 3 segments as you can see here. Now let's learn about the 3 important segments. Segment 1. Initially, when the urinary bladder is empty, the intravesical pressure is 0. When about 100 milliliter of fluid is collected, the pressure rises sharply to about 10 centimeter water. Segment 2. Segment 2 shows the plateau, that is, no change in intravesical pressure. It remains at 10 centimeter water even after introducing 300 to 400 ml of fluid. It is because of adaptation of urinary bladder by relaxation. It is accordance with Laplace law. Let's learn about the law of Laplace. According to this law, the pressure in a spherical organ is inversely proportional to the radius, the two remaining constant. That is, if radius is more, the pressure is less, and if radius is less, the pressure is more, provided the tone remains constant. So, this is a simple and brief description about Laplace law. This is a pressure which is directly proportional with the tension, and it is inversely proportional with the radius. Accordingly, in the bladder, the tension increases as the urine is filled. At the same time, the radius also increases due to the relaxation of the detrusor muscle. Because of this, the pressure does not change and plateau appears in the graph. With 100 ml of urine and 10 cm water of intravesical pressure, the desire for micturition occurs. Desire for micturition is associated with a vague feeling in the perineum, but it can be controlled voluntarily. An additional volume of about 200 to 300 ml of urine can be collected in bladder without much increase in pressure. However, when total volume rises beyond 400 ml, the pressure starts rising sharply. Now let's talk about the segment 3. As the pressure increases, the collection of 300 to 400 ml of fluid, the contraction of the detrusor muscle becomes intense, increasing the consciousness and the urge of micturition. Still, voluntary control is possible up to the volume of 600 to 700 milliliter approximately, at which the pressure rises to about 35 to 40 centimeter water. When the intravesical pressure rises above 40 centimeter water, the contraction of the detrusor muscle becomes still more intense, and voluntary control of mixture is not possible further. Now, pain sensation develops and micturition is a must at this stage. Micturition reflex. Micturition reflex is the reflex by which micturition occurs. The reflex is elicited by the stimulation of stretch receptors situated on the wall of urinary bladder and urethra. When about 300 to 400 ml of urine is collected in the bladder, intravesical pressure increases gradually. This stretches the wall of bladder, resulting in stimulation of stretch receptors and generation of sensory impulse. Pathway of micturition reflex. Sensory or afferent impulses from the receptors reach the sacral segments of spinal cord via the sensory fibers of pelvic or parasympathetic nerve. Motor, that is efferent impulses produced in spinal cord, travel through motor fibers of pelvic nerve towards bladder and the internal sphincter. Motor impulses causes contraction of detrusor muscle and relaxation of internal sphincter so that urine enters the urethra from the bladder. Once urine enters urethra, the stretch receptors in the urethra are stimulated and send afferent impulses to spinal cord via pelvic nerve fibers. Now, the impulses generated from the spinal centers inhibit pudendal nerve. So, the external sphincter relaxes and micturition occurs. Once a micturition reflex begins, it is self-regenerative. That is, the initial contraction of bladder further activates the receptors to cause still further increase in sensory impulses from the bladder and urethra. These impulses in turn cause further increase in reflex contraction of bladder. The cycle continues repeatedly until the force of contraction of bladder reaches the maximum and the urine is voided out completely. During micturition, the flow of urine is facilitated by the increase in the abdominal pressure due to the voluntary contraction of abdominal muscle. Now here we have a simple flow chart for understanding the whole pathway. First, filling of urinary bladder occurs. This in turn acts for the stimulation of stretch receptors, and this stretch receptor stimulation creates impulses, that is afferent impulses, which pass via the pelvic nerve to the sacral segments of spinal cord. Once it reaches the spinal cord with the same pelvic nerve, it transports impulses, that is efferent impulses, to the detrusor muscle and internal sphincter, where the contraction of detrusor muscle takes place and at the same time the relaxation of internal sphincter takes place. This results in flow of urine into the urethra and stimulation of stretch receptors present there. Hence, the afferent impulses via pelvic nerve inhibits the pudendal nerve. which results in the relaxation of external sphincter, and this causes voiding of urine or micturition. Now let's talk about some higher centers for micturition. We know that spinal centers for micturition are present in sacral and lumbar segments, but these spinal centers are regulated by some higher centers. The higher centers which control micturition are of two types, that is, inhibitory centers and facilitatory centers. Inhibitory centers for micturition are centers in midbrain and cerebral cortex inhibit the micturition by suppressing spinal micturition centers. Facilitatory centers for micturition are centers in pons facilitate micturition via spinal centers. Some centers in cerebral cortex also facilitate micturition. Now let's talk about some important physiology about micturition. Abnormalities of micturition. Atonic bladder. Effect of destruction of sensory nerve fibers. Atonic bladder is the urinary bladder with loss of tone in detrusor muscle. It is also called flaccid neurogenic bladder or hypoactive neurogenic bladder. It is caused by destruction of sensory, that is, pelvic nerve fibers of urinary bladder. Due to the destruction of sensory nerve fibers, the bladder is filled without any stretch signals to spinal cord. Due to the absence of stretch signals, detrusor muscle loses the tone and become flaccid. So the bladder is completely filled with urine without any micturition. Now, urine overflows in drops and when it enters the bladder, it is called overflow incontinence or overflow dribbling. Conditions for destruction of sensory nerve fibers. Number 1 is the spinal injury. During the first stage, that is stage of spinal shock, after injury to sacral segments of spinal cord, the bladder becomes atonic. Syphilis. Syphilis results in the degenerative nervous disorder called tabes dorsalis, which is characterized by the degeneration of dorsal, that is sensory nerve roots. Degeneration of sensory nerve roots of sacral region develops atonic bladder. The atonic bladder in tabes dorsalis is called tabetic bladder. Automatic bladder. Automatic bladder is the urinary bladder characterized by hyperactive micturition reflex with loss of voluntary control. So, even a small amount of urine collected in the bladder elicits the micturition reflex, resulting in emptying of bladder. This occurs during the second stage, that is, stage of recovery after complete transection of spinal cord above the sacral segments. During the first stage, that is, stage of spinal shock, after complete transection of spinal cord above the sacral segments, the urinary bladder loses the tone and becomes atonic, resulting in inflow incontinence. During the second stage, after shock period, the micturition reflex returns. However, the voluntary control is lacking because of absence of inhibition or facilitation of micturition by higher centers. There is hypertrophy of detrusor muscle so that the capacity of bladder reduces. Some patients develop hyperactive micturition reflex also. Uninhibited neurogenic bladder. This bladder is a urinary bladder with frequent and uncontrollable micturition caused by lesion in midbrain. It is also called spastic neurogenic bladder or hyperactive neurogenic bladder. The lesion in midbrain causes continuous elicitation of spinal micturition centers, resulting in frequent and uncontrollable micturition. Even a small quantity of urine collected in bladder will elicit the micturition reflex. Nocturnal micturition. This is quite common. Nocturnal micturition is the involuntary voiding of urine during night. It is otherwise known as enuresis or bedwetting. It occurs due to the absence of voluntary control of micturition. It is common and normal process in infants and children below 3 years. It is because of incomplete myelination of motor nerve fibers of the bladder. When myelination is complete, voluntary control of micturition develops and bedwetting stops. Nocturnal micturition occurs after 3 years of age is considered abnormal. It occurs due to the neurological disorders like lumbosacral vertebral defects. It can also cause due to physiological factors. Loss of voluntary control of micturition occurs even during the impairment of motor area of cerebral cortex. Hope you have understood the video. Like, subscribe and press the bell button for more videos. Thank you. Thanks for watching.